Anjana, we can start.
Yeah, okay. Good morning, everyone. So I'll be speaking on the shock. I think that's
Ma'am,
the
just 1
most,
second, ma'am.
yes.
Just 1 second. Ma'am, please start.
Morning, everyone. So I'll be speaking on approach to an undifferentiated shock, which is the most common thing I think we see in ICU. All the patients, most of the patients, that's the presentation. Uh, So what is a shock? Shock is the clinical expression of a circulatory failure. So it is basically characterized by an inadequate oxygen delivery. Basically, there's an inadequate oxygen delivery to meet the metabolic demands, resulting in the tissue hypoxia. And the simple terms if we describe it. Now, most of the patients we see in the ICU, they come in a shock, and effects of shock are actually reversible if we act on time, but it becomes irreversible if the action is not immediate and results in the multi-organ failure and death, which we see most of the times in ICUs. Now, undifferentiated shock means that you have made a diagnosis of a shock, but you don't know what the underlying etiology is. Definitely, you know that a patient is in shock, but why a patient is in shock, we don't know. So that is an undifferentiated shock, and it does take some time to understand the reason behind the shock. So what are we going to do till the time we know why patient is in shock? That's what I'm going to speak on. Now, so how do you diagnose a shock? I think this everyone knows the clinical signs based on the hemodynamic signs and the biochemical force. So that will be like your blood pressure on the lower side, systolic less than 90, or mean arterial pressure less than 60, 65, and tachycardia. That's the usual presentation. Then when you examine the patient, you will see the signs of tissue hypoperfusion, which indicates that your end organs are affected. Patient will be in the altered sensorium, cold, clammy, your urine output will be less than 0.5 ml per kg per hour, and of course the lactates will be high. I think this is the common thing which we see, the hypotension, signs of hypoperfusion, and the lactates which will go on rising. So these are the components of shock. Now, stage of a shock. Now, different patients will come to the ICU at different stages. Uh, you will see a patient in a pre-shock. I think that is the time when you have to act on the patient, in which at that time, patient will be in a compensatory state. Like there will be the compensatory mechanisms which are working. Your BP must be will be maintained, but patient will be tachycardic. You will see a toxic look on the patient, will look sick, but blood pressure may be normal. Now, if you don't act at that point, within a very short time, patient will go in a frank shock where you will see hypotension and an early organ dysfunction where patient decompensates. That's called a decompensation. We'll see hypotensive, altered sensorium, urine decreasing, lactates going up. Now, if you don't act at this stage, patient will go in an end organ dysfunction, which is an irreversible, where patient will go in a multi-organ failure and all the vital organs will start getting affected. So our action at an early stage of a shock is essential and important. So in short, I'll just go through what are the kinds of the shock we come across. Distributive, hypovolumic, all the time we'll see in ICU, cardiogenic, anaphylactic, obstructive, and neurogenic shock. Now, distributive is a vasodilatory shock. So this happens mainly because of an inflammation. Now, your inflammation can be because of infection, or it may be non-infective as well. Now, infection means sepsis, right? So sepsis is a vasodilated shock where you have a diffuse vasodilatation. There's an inflammatory response. So in that case, you have a severe circulatory, cellular, and metabolic abnormalities resulting in a tissue hypoperfusion. Patient will manifest as a hypotension and there'll be a vasopressor requirement, right? The non-infective vasodilatation will be in an inflammation like burns, pancreatitis, or embolism. So that will be the response of the body to different, like to the inflammation, because of which patient will go on a shock. So infective and non-infective. Now, anaphylactic is mainly the hypersensitive reaction to any antigen, resulting in a cardiovascular collapse or respiratory distress. Neurogenic, any trauma to the brain or spinal cord, where there's a disruption of the autonomic pathway and your vagal tone and all goes down and patient goes in shock. That's a neurogenic shock. Endocrine, of course, we see it less often, but it's also common because of the adrenal failure or thyroid if it's involved. That's called a mixed edema. Hypovolemic, all the time we see, which is like hemorrhagic or maybe non-hemorrhagic. Hemorrhagic, I think the trauma patients or any patient who comes bleeding, who has been on anticoagulation, bleeding a lot, so we'll go in a hemorrhagic shock. And non-hemorrhagic can be the GI losses, renal losses, or third space, like in the burns, pancreatitis, where patient goes in a shock where the capillaries are leaky. So that's a hypovolemic shock. Now, cardiogenic, well, MI or myocarditis or any cardiac involvement, where the cardiac output gets affected, so cardiogenic shock, and obstructive pulmonary embolism or severe pulmonary hypertension, tension, pneumothorax, or pericardial tamponade. So these are the different causes or the different types of the shock we encounter. But when you encounter a patient, we don't know what is the type of shock. So how we should approach such patients. Okay, this is a summary of the different kinds of the shocks. So distributive vasodilated, cardiogenic will be vasoconstricted, they'll be cold and all, may have a normal blood pressure as well, then obstructive. Right. So now coming to the management, why we have to manage them early? Because the adequate hemodynamic support of the patient in the shock has to be given so that you prevent the organ dysfunction, because then your process becomes irreversible. So resuscitation should be started while you are investigating the patient for the cause. Like what kind of shock is it? Your resuscitation should start at that point. So it should be a problem oriented regardless of the cause, although the treatment that are used to reach these goals may differ. Now, what are the components of the resuscitation? There are three things. One is ventilate, infuse, and pump. Ventilate means it's same as ABC what you do. That ventilate, take care of the oxygenation of the patient. Infuse is a fluid resuscitation. Pump means you're working on the heart so that your cardiac output is maintained and your end organ perfusion does not suffer and the end organ damage does not happen. And you can simultaneously investigate the patient for the cause of a shock or what is the real reason behind the shock. Now, ventilatory support, why do you need to do that? You have to maintain the oxygen delivery to the patient, to the tissues. You can give oxygen if patient is not, if the work of breathing is not that much, you can target your oxygenation to 55 to 70 millimeter of mercury, or saturation of 88 to 92% is also okay. Now, if the patient is dyspneic, there's increase in the work of breathing, intubation is extremely important. We cannot wait, okay, the shock will improve, the breathing will improve. That should not be our approach, because increase in work of breathing, hypoxemia, acidosis will further worsen your shock and it goes in a vicious cycle. Okay, so the airway and oxygenation is extremely essential before you address the shock. Your oxygen levels have to be maintained, right? So intubation reduces the oxygen demand of the respiratory muscles and decreases the left ventricular afterload by increasing the intrathoracic pressure. Now coming to the fluid resuscitation, I think this everyone knows. Okay, the patient comes in shock, you'll put a cannula and start resuscitating the patient, right? Now, you don't have to worry about the lines at that point. Okay, I'll put a central line, arch line. That I don't think should be the approach. Even if you have a large bore cannula, you can give the fluids through that. You can give a vasopressors also through that till you have time, till you get a time to put in the line. So you don't have to stress yourself, okay, I have to put a central and heart line. You can resuscitate a patient with a good IV cannula. Okay, so while you are doing that, in the meanwhile, you draw the blood for the counts, coagulation, ABG to look at the lactates or other investigations which you want to be sure that, when you're working up the patient. Now, there are many measures to guide the resuscitation, which I'll be explaining in next slides. Well, echo and bedside ultrasound has become extremely important for most of the patients now. So echo and ultrasound should be on the bedside, which will actually guide you about or tell you the reason why patient is in shock. You can figure out many things on echo and ultrasound, and then you can do a shock targeted management. But your resuscitation should be on while you're doing all these things. Now, so in the meanwhile, you ask the history for the background, allergies, anaphylaxis, or any cardiac history. Then, so that details also you can ask in the meanwhile while you are resuscitating the patient. Now, what should be the aim of resuscitation? So you need to optimize the ventricular filling, right? So patient will be hypovolemic or obstructive, you have to optimize the preload. Second is optimize your cardiac output and optimize your afterload, especially the vasodilatory shock. So your aim is to maintain the fluid therapy or give the fluid therapy to improve the microvascular blood flow and improve the output. An individualized strategy of resuscitation should be given depending on the fluid tolerance and responsiveness. Now, earlier we used to do a lot of fluids. Okay, give fluids, give fluids. That used to be the strategy. But now there are studies which have shown that excess of fluids which you give are associated with end organ dysfunction and mortality. So your resuscitation when you're resuscitating has to be guided by several parameters. It should not be a blind fluid resuscitation. Now, there are many parameters which have come up over the past many years. Clinical parameters, fluid challenge, static and dynamic. I'll take them in short. Clinical means you will look at clinically, like how the patient is, how the sensorium is urine coming, has lactate settled, has a blood pressure come up, has tachycardia settled. So that will be your clinical assessment of the patient while resuscitating. Even if you don't have other tools, clinically you can resuscitate a patient and see all the clinical parameters. You see urine is coming, acidosis has resolved, lactates are coming down, patient is conscious oriented. That means whatever you're doing is working. Okay. The next thing is a fluid challenge, where you give a small amount of the fluid and then see the response. I'll come to the details of that. And next will be the static. Static parameters we used to use like the CVP and pulmonary artery occlusion pressure and all these things. But I think this everyone knows that your filling pressures, they really do not correspond to it. But still you can use it. You can see a series of the values that still carries an importance and it is used in some centers still. The most commonly which we use now is the dynamic parameters, which is even recommended by the sepsis guidelines, where you will use the dynamic parameters on the patients who are on the mechanical ventilation. Let me go through it very quickly. So fluid challenge is this, the principle is that you give a small bolus of the fluids, right? You can give 250 to 500 in a very short period of time, 10 to 15 minutes or 5 to 10 minutes. It's a small quantity of fluid which stretches the ventricle, but you have to give it in a very short time. It will stretch the ventricle and improve your cardiac output or stroke volume and see the response, of course. So if the patient is responding, that means patient is fluid responsive. That's a fluid challenge. So you have to avoid a fluid loading, which was done before, where you would give a fluid unblinded. Okay, give 1 liter of fluid, give 2 liters. That should not be the thing. Okay, initially you can start, but then it has to be a guided fluid resuscitation to prevent the fluid overload. Now, this passive leg raising, I think it's a reversible fluid challenge where you are doing an auto transfusion. Okay, that is equivalent to a fluid challenge which you give IV. So I'll tell you how to do it. So cardiac output and pulse pressure changes we see in response to PLR, and they are predictive of the fluid responsiveness, and they are not dependent on any mode of ventilation. You can see it in a spontaneously breathing patient as well. So you raise the legs to 30 to 45 degrees above the chest, hold it for 1 minute. There will be an increase in the venous return and the effect will last for some minutes. If patient is fluid responsive, you will see an improvement. So this is how it is done. So it will induce a change in the aortic flow by more than 8%, and that is highly predictive of fluid responsiveness in the ventilated patients or in the patients who have a spontaneously breathing efforts and it's not affected by the arrhythmias, unlike the other dynamic parameters. I'll come to those parameters also. So this is the main principle. I'll only explain the principle. on which the stroke pressure variation and pulse pressure variation and SVV works. Means when you are ventilating the patient in a positive pressure, your pleural pressure goes up. The venous return will come down, your preload decreases, and RV afterload goes up. Okay, so your RV stroke volume will decrease. Naturally, if RV stroke volume decreases, it will decrease the left ventricular stroke volume as well, which happens in the expiratory period, because there is some time, there's some transit time for the blood to reach from right ventricle to the left ventricle. So during inspiration and expiration, you will see the variations. So this is the main principle on which your parameters work. So this is systolic pressure variation. You can see in the mechanically ventilated patients. Then pulse pressure variation. If the variation is more than 13%, they are the patients who are likely to respond by increasing the cardiac output by more than equal to 15%. Okay. So this is the type of the trace you will see in the pulse pressure and the okay. Now SVV means a stroke volume variation. So it reflects the sensitivity of the heart to the cyclic changes in the cardiac output, which is induced by the mechanical ventilation. So it's a percentage of the maximum and the minimal stroke, basically, which is averaged over a period of 10 seconds. Again, so SVV more than 10% means patient may be dry. So it's highly predictive of preload responsiveness. I think this I have explained already. Basically, these three things you can see in a mechanically ventilated patient. But the problem is that patient should not be spontaneously breathing, or your tidal volume variation. It should not vary. It should be a fixed tidal volume. If it varies, then it may not be correct. And in case there are arrhythmias, it may not be correct. So these are the problems with these parameters. The IVC, I think that's the most common thing we do in ICU. We measure the we measure the IVC and then see the variability, and depending on that, we resuscitate the patient. If it's more than 50% variability or more than 30%, we think that patient is fluid responsive, and then again we check the IVC and do it again and again and try to resuscitate. Now, IVC also has its own disadvantages because it varies in the spontaneously breathing patient, and every time it may not give you a correct impression. But still, I think this is widely used. We use it most of the time in ICU. Now, the thing which I find very useful is a velocity time integral. I included it in this because I think that I found that it's very easy to do, and it is a very good measure you can do with the echo. Of course, you need an echocardiography for this. So you basically measure the flow at the left ventricular outlet. Okay. Usually you measure the velocity at that point where at the left ventricular outflow, and it's 18 to 22 centimeters. So when you measure it, I won't go into the details how to measure it, but it is done with the echocardiography at the level of left ventricular outflow. So when you see a flow with respect to the time, after that, you give a fluid bolus and then see how much it varies. And if it is more than 10% variation is there, 10 to 15%, that means patient will respond to your fluid. So velocity time integral is a very, I found it very useful personally. Then there are other parameters also. I won't go into details of others. Then this one also I found interesting, that end expiratory occlusion test, where you interrupt the ventilation and expiration for a few seconds, which decreases the cardiac preload in mechanically ventilated patient, and cardiac output increases more than 5%, means patient is fluid responsive. So VTI, I think I found very useful in the ICU. We should do, after IVC, that's what I felt. Now, which fluids do you give? Now you have assessed the patient. You know if your patient is fluid responsive, and you want to give fluids. Now, which are the fluids you can give? It can be crystalloids or colloids. But we know there are the studies which have not shown any mortality benefit in between, whether you give a crystalloid or a colloid. There's no extra benefit with the colloids. Now, crystalloids, again, you have the chloride-rich or balanced crystalloids. Now, there were studies which actually suggested that, okay, you should use the balanced salts, balanced solutions and not the chloride rich, because there is a lot of chloride in that results in the hyperchloremic metabolic acidosis, renal dysfunction, and all those things. Uh, but most of the studies which they have not shown us any difference between the two fluids. Basically, there is no mortality benefit on using the chloride-rich solutions, or sorry, on avoiding the chloride-containing solutions compared to the balanced solution, and neither there was any effect on the AKI or RRT, whether it worsened your renal function or not. So most of the studies have not shown, but we still tend to use a balanced solutions, I think, in most of the ICUs. But there is no difference between any fluid except hydroxyethyl starch, which was used before, which has been found to be harmful for the patient, affecting the coagulation and your renal function. It's no longer used. Albumin, of course, there is no role here, but there are many centers where you use the albumin when there is a large volume resuscitation, or where you see may benefit and you want to retain the fluid intravascular compartment, but there is no extra benefit. So crystalloid, I would say, is for resuscitation, whether you used a chloride rich or the balanced solution. All right, now vasopressors. Now, why do you need to start the vasopressors? What agent you should start, when to start, what target, and what you do if it is refractory. So these are the questions, right? So you're resuscitated, so you have resuscitated your patient, you have secured an airway, you have given fluids, you know how to see the fluid responsiveness, and according to that, you have given the fluids and you have chose your fluids, what you want to do. Next, you will look at the vasopressors. Now, why do you need the vasopressors? When you're resuscitating the patients, it takes some time for the blood pressure to come up, right? So the more the duration patient is in hypotension, there is a risk of high risk of a organ hypoperfusion, okay, and organ dysfunction. So you have to maintain that mean arterial pressure or a perfusion pressure to maintain the perfusion to your vital organs, right? So you have to correct the hypotension with vasopressors, improving the organ perfusion. Now, when should you start vasopressors? So earlier we used to say, okay, give fluids, patient not responding, start vasopressors. But now what is recommended is that you can start vasopressors in the beginning itself while you are resuscitating the patient. You can give it through your peripheral line. You don't need a central line. Initially, when you're resuscitating, what is important is to maintain perfusion. So somehow you have to get that mean arterial pressure up or your perfusion pressure up to maintain the end organ perfusion. So that should be your priority. So early vasopressor administration will improve your microcirculation, tissue oxygenation, and perfusion. So they increase your systemic vascular resistance, and there is also decrease in the risk of the fluid overload. Okay, so when you have achieved your target map, of course, you will fill up the patient, but noradrenaline or any vasopressor will help you to maintain that perfusion pressure quickly so that your end organ doesn't damage or your microcirculation is not affected. So your aim is to maintain, that should be the aim. Somehow you have to maintain your perfusion. Now, what agent should you use? The first line agent is a noradrenaline. Okay, now how does the noradrenaline work? It mainly works on the alpha receptors, causing the peripheral vasoconstriction or a SVR, raising your blood pressure, diverting the blood from the peripheries and gut towards the heart and the brain. Now, it does have some beta activity also, means it acts on the heart, improves your cardiac output to some extent. So, but mainly it is alpha receptor action is there. So, of course, I think I mentioned earlier also that you can give it through the peripheral line. You don't need the central line initially. Of course, later on you have to go. Next is the dopamine, which is no longer used. Most of the, except for the spinal shock, sometimes we use it. Otherwise, now we don't use it that much. So it has a beta adrenergic effect at a low doses and alpha adrenergic effect at higher doses. At a very low doses, it was believed that it improves the renal and splanchnic circulation and renal function, but studies have not shown any benefit with that or any outcomes, primary or secondary. In fact, it is arrhythmogenic and immunosuppressive, affecting the prolactin release and all those things. Coming to the studies which have been comparing the two vasopressors, the dopamine and norepinephrine, so there has been they have found that there's no difference in the 28-day mortality between the two vasopressors, and noradrenaline it seemed to be a safer agent because arrhythmias were more seen with the dopamine and there was a high risk of death with that. Now this is a landmark trial in India which actually looked at all the shock states where they found that there was no difference in the mortality between the two groups, but dopamine was arrhythmogenic. And when they did a subgroup analysis, the patients with cardiogenic shock with a higher heart rate, they had a poor outcomes. There was more rate of death. So this study was done in all the shock states. Coming to adrenaline, now it's adrenaline has an alpha and a beta adrenoreceptor agonist. Both the receptors are affected. Now, alpha adreno receptor effect is mainly at the higher doses. At the low doses, adrenaline acts as an inotrope. Now, it also increases the cellular metabolism. It produces the biochemical changes in the form of increase in lactates and all. There is no additional benefit between adrenaline or noradrenaline that the studies have shown, but it is used as a third line agent in shock. Now, this is a trial where they compared actually the adrenaline and they found that there was no difference, there was no evidence for the difference in all-cause mortality in the patients receiving short-term or long-term with epinephrine or where they combined with norepinephrine with dobutamine. In fact, epinephrine was associated with decrease in arterial pH or the lactate concentration, but of course, there was no harmful effect which was seen with the high lactates as well, but it did show the biochemical. Now, this is another trial which again compared epinephrine and norepinephrine for the cardiogenic shock. There also they found that both the drugs had the same effect on the blood pressure, cardiac index. In fact, they saw that adrenaline was harmful. There was a higher incidence of a refractory shock with adrenaline. Now, coming to the vasopressin, we know that in distributive shock or sepsis, there's a relative vasopressin deficiency. Surviving sepsis guideline, it has recommended vasopressin as a second-line agent. It reduces vasoconstriction through the E1 receptor. Now, there's a landmark trial, that's a VAST trial, which has shown that there is no mortality difference if you add the vasopressin. There was, no mortality benefit. But of course, they saw that the patients where vasopressin was given, they showed it had a norepinephrine sparing effect. Basically, there was a lesser dose of noradrenaline which those patients required after adding vasopressin, but there was no mortality benefit with the vasopressin, but it reduces your dose of the norepinephrine, which was they saw in the subgroup analysis that those patients did well where a lower dose of the noradrenaline was given. So we use that as a second line agent so that your noradrenaline dose can be reduced in a sepsis or a shock patients. Now, this is another landmark trial. This is a VANISH trial, which again looked at the vasopressin or norepinephrine. They looked at the kidney failure basically. That if vasopressin improved the outcomes in terms of the renal function, but it did not improve any kidney failure free. So both the trials did not actually show the benefit, but of course we use vasopressin when NORAD is at a very higher dose so that you can taper off your NOR. Okay, it does help. So it's a second line agent. Now, coming to the inotropes. What do you mean by inotropes? Means that it has a positive effect on the heart, basically, increasing your cardiac contractility, cardiac output. So mainly we use it for a cardiogenic shock where there's a lower cardiac output states, right? So we have two agents, that's the dobutamine and milrinone. Now, dobutamine acts through beta-1 and it has some beta-2 activity as well. So by acting on the beta-1 receptors, it improves the contractility and your cardiac output. A problem is that it has a beta-2 effect also affecting the peripheral blood vessels, causing vasodilatation, and patient can have a hypotension with dobutamine. So you can use it in combination with the vasopressor like noradrenaline, which causes the increase in systemic vasoconstriction. So both dobutamine and noradrenaline can be used together in case of a cardiogenic shock. So that's the recommended drug for cardiogenic shock. Then milrinone, why it has come up now? Because its mechanism of action is completely different compared to the dopamine, dobutamine, which act on the adrenoreceptors. It is a phosphodiesterase 3 inhibitor that works through a mechanism independent of adrenoreceptors. It increases the cyclic AMP basically. So you can use it where there is a down regulation of the adrenoreceptors where catecholamines, the patient can be refractory to the catecholamines in those cases where the patients are on beta blockers. But the problem with milrinone is that it has a long half-life and it causes hypotension because it sets a vasodilatation. Now, this is a trial which has compared both milrinone and dobutamine, and there is no difference with respect to any outcomes between the two. So we still tend to use the dobutamine more than the milrinone. But but milrinone also appears to be promising. So till this time, I think I'll summarize. So what we have done is we have secured the airway of the patient. You have resuscitated the patient with the fluids. We have worked on the vasopressors to maintain the cardiac output to your blood pressure so that your end organ perfusion is okay. So these are the different vasopressors which you can use and reach your target. Now, in the meanwhile, you are working up the patient for the cause of a shock, and you have to do a shock specific management as well, right? You will do your echo, you will do the ultrasound, you will look, if it is a sepsis, you will look for a source of a sepsis as well. So I'll come to that part also. Now, so what is your goal now? You have done your thing. What is your goal after doing few resuscitations, starting the patients on vasopressors and all? You should have a sufficient blood pressure to maintain an adequate oxygen delivery to the tissue, right? That should be the aim from the beginning. I have been stressing on that. So mean arterial pressure of 65 is usually a target, but you may consider lower targets if patient is bleeding, for example, in hemorrhagic shock, where you may try to maintain a lower MAP, or during perioperative hypotension and anesthesia. Of course, we don't do that. And higher MAPs may be important in case of a raised intracranial pressure or spinal injury where you want to maintain the cerebral perfusion pressure. So your treatment goals are to be individualized, taking the consideration the clinical situation. To restore the tissue perfusion depending on the clinical parameters or your biochemical parameters. Now, biochemical parameters, the most important is the lactate, which increases because of the abnormal cellular function, mainly because of anaerobic metabolism. So your serial lactate measurements, at least 20% decrease should be there over a 2-hour period, has been associated with a decrease in hospital mortality. I think this I have stressed earlier also. The clinical judgment and the clinical parameters are very important. Even if you are in an outskirts where you don't know how, where you cannot do this fluid responsiveness and all these things, but clinical thing is the most important. Still, we have so many tools there's so many things which have come over the period of years to look at the fluid response or to look at the tissue perfusion. Still, I feel that the clinical judgment is the best. How you see the patient clinically, how you approach your patient clinically. So this one slide I've added in the microcirculation. These things are not available actually in every center, but NRS I have seen still. So you can have a handheld devices for orthogonal polarization spectral imaging and side stream dark field imaging, where you can visualize the microcirculation. You can see the flow in the sublingual area. NRS is available in some of the centers where you can use a near infrared spectroscopy to see for the oxygen saturation, fraction of oxyhemoglobin and deoxyhemoglobin. That gives you an idea about the peripheral tissue perfusion, because ultimately the microvascular dysfunction is associated with the worse outcomes. So it's not really done in all the centers, but we should know this. Now, shock-specific management, I don't think that is a part of the discussion, but I can go through. Now, you have resuscitated your patient, you have maintained a map which will improve your organ perfusion, but then you have to look at the cause of the shock, right? In the meanwhile, you start investigating the patient, send the cultures, start the antibiotics. You will see, you will get the x-rays or ultrasound, you will see consolidation. Okay, patient has a pneumonia or UTI, whatever. Start the patient on a broad spectrum antibiotics. And of course, the source control is the ultimate thing, which will actually maintain your patient. Hmm? Now, cardiogenic shock, stenting, revascularization of the patient. You will come see echo will be effective. While you're doing the echo, you'll make out, okay, there's a LV dysfunction, there are regional wall motion abnormalities. And then you will further investigate the patient and see if it's ACS and revascularization. I think that's a main thing to be done. And mechanical circulatory support and echo, that is a last resort in case of the cardiogenic shock. Similarly, obstructive shock, if it's a pulmonary embolism, thrombolysis, thrombectomy, pneumothorax, if it is there, you have to put in a chest tube, or cardiac tamponade, of course, you have to do a pericardiocentesis to relieve the shock. Obstructive shock will not improve. You have to be very, very quick in these cases. Where even after resuscitation, starting the vasopressor, you have to be very quick in diagnosing the obstructive shock and act very quickly. That gives you very less time. Sepsis may give you some time, but obstructive shock, you have to be very quick. Anaphylactic shock, again, stop the offending agent, epinephrine, antihistaminics, and steroids. Hypovolemic or hemorrhagic, I think this you can make out patient is bleeding. Okay, you'll give blood products, correct the coagulopathy, resuscitate the patients, control the source of the bleeding. So that will be for the hemorrhaging. And hypovolemic also, you have to resuscitate with the fluids and all. So basically, the stress is on the treatment of a cause of a shock. Then only whatever you have done, whatever resuscitation has been done till now, it will be maintained only once you deal with the cause. So to summarize, your aim is to salvage a patient, right? So obtain an acceptable blood pressure, perform the life-saving measures, optimize your oxygen delivery, optimize your mean arterial pressure, optimize the cardiac output, look at the patient clinically in terms of end organ perfusion, provide the organ support, minimize your complications, and then when you have dealt with the cause of a shock, you have to de-escalate, wean the patient from the vasoactive agents, try to achieve a negative balance. You must have loaded the patient. So you have to assess your fluid state at every stage of resuscitation. Well, otherwise, so initially give fluids. Once the patient recovers, you have to reassess whether you have to take back the fluids or not. That also is very important for the patient to come out of the ventilator or whatever support the patient needs. Thank you.
Thank you, Anjana. Excellent presentation as always.
Thank you.
Ghanshyam?
Thank you, Anjana.
Yeah.
See, it's always a challenge to manage any patient who is in shock.
Yeah.
The challenge becomes more complicated when you do not know the exact etiology.
Yes.
By and large, in a large number of patients, you may be the clinical presentation, the clinical history, or your echo findings might hint you what is the probable cause. But there are many such situations where the cause may not be very clear. For example, let us assume that you have a patient who is a cardiomyopathic patient who is on diuretics with a poor LV function, who's been on diuretics for a long time. Now, either presents with a diarrhea, gastroenteritis, or say the patient presents with fever.
Yeah.
Now, what is the component of each type of shock becomes very difficult to measure.
Very difficult. Yes, of course.
Right.
Yes.
And in such situation, it becomes very because you have a patient cardiomyopathy or LV function, and you are suspecting infection and sepsis component. On one side, the septic shock speaks about being aggressive with fluids. On the other
Yes.
side, you are worried about whether your LV dysfunction is going to, your
Yes,
LV function, will
cardiac,
it
yes,
allow
yes,
you to actually give that kind of a thing? And we don't know many a times what the baseline cardiac function is.
yes,
So is it a cardiogenic shock? Is it a septic shock? Is it a combination of both? Which component is the predominant component? So many times it becomes very difficult for us to actually kind of quantify each component.
yes,
I think the only thing that we can do in such situations is to be a little guarded, right?
yes,
Frankly speaking, again, if you look at the number of options that you have in your hand in dealing with any kind of shock is less.
yeah,
So your repeated clinical examinations, your
yes,
ultrasound echo,
yes,
look at perfusion markers like your AVCO2 gap, your SCVO2, your
yes,
lactates,
yes,
your lung ultrasound, your echocardiography. And it's just not one time, but repeating these
repeating,
over a period of time to see how the trend is evolving with your interventions is what will help us in probably trying to, one, resuscitate, and second, you may not be able to identify the etiology at the first go, but I think periodically when you keep looking at the trends, you will have some idea of what could be the actual cause of shock.
yes,
And thirdly, uh, you know, in the first maybe 24, 48 hours, we may have to be very, very aggressive, probably with trying, especially if you don't know what the exact etiology of shock is, trying to be more, increase your coverage. For example, even if there is a very, very mild focus of infection and nothing else points out, maybe being very liberal with your antibiotics and then maybe coming back to de-escalation, especially if
yes,
you're having somebody who's on a immunocompromised background, right? So, it is always a challenge. And I think repeated examinations
right,
and looking at how your interventions are resulting in organ perfusions is what will help us come out of some of these situations. And thank you, Srinivas.
yes, yes. So
Yeah.
I think each patient is different, and now echo and ultrasound has become a part, right? So after every, I feel like we do after every half an hour or after 15 minutes, we'll be looking at the heart, looking at the lung, looking at the parameters. I think that has become a part of the bedside examination. But of course, clinically, that still I feel like, that is the main thing, and the other biochemical parameters which guide us. Yeah.
Srinivas, we can't hear you. Hello.
We can't
Yeah,
hear.
another point that I would just like to make is
Yeah.
we should always have an idea about what's happening at the macro circulation and at the micro circulation.
Yes.
Hello.
Sham,
Yeah, we were not able to hear you till now.
can you hear me now?
Yes.
Yeah.
Yeah. Yeah. So I think essentially what we understand about hemodynamics after all these years is that there's no single parameter which will guide you on the diagnosis of etiology of shock. There is no single test which will tell you that this is the kind of shock. The only thing we know, shock can happen with a normal mean arterial pressure also. And a target of 65 to 75 is probably the best way to manage shock, is what we know after all these years of understanding this complex pathophysiological state. But it is not as complex as we think it is. If you have a very clear understanding that shock can be just either a vasodilatory or a low vascular resistant state or a vasoconstricted or high systemic vascular resistant state, patients into which aspect of shock they are in. And because a low systemic vascular resistance or vasodilated, usually warm peripheries with a hyperdynamic pulse with a wide pulse pressure and hyperdynamic ventricle on ultrasound and a normal or a collapsing IVC with flat neck veins, you are either dealing with a septic shock or a neurogenic shock in the early phase. On the other hand, if you are looking at a narrow pulse pressure, a cold peripheries, a hypocontractile ventricle, and a distended IVC, and a flat and a distended neck veins, you are dealing with a cardiogenic shock. Sometimes hypovolemic and hemorrhagic shock can also present like this with cold peripheries and hypocontractile heart because of
Srinivas, we lost you again.
Yeah, I think.
Hello. Hello.
It's not there.
No, sometimes is the internet at his place
Yeah,
plays a little mischief.
I can see.
Yeah. So can you hear me now?
Yeah, we can hear you now. We lost you from the hypovolemic.
Yeah. So shock is never the end point of a diagnosis. It is the beginning of a diagnostic algorithm. But the point to remember is that it is not a watertight compartment. For example, somebody with septic shock can either develop coronary ischemia, can either develop pulmonary embolism, or it can develop septic myocardial depression. So what is the pathophysiological condition is the one that determines your therapeutic intervention, although treatment of the cause is the main solution to management of any kind of shock. So those of you who have logged in and have queries or comments on this, please do post them on the group from which you got this link, and the speaker and the moderators will try to answer them in the quickest possible time frame. Please do join us next week, and also do join us this weekend for a journal club on the role of surgical evacuation of intracranial hematoma. Please do keep in touch with the Higgs group for more academics in the days to come. Thank you very much. Have a good day. Bye bye.
Thank you, Anjana.
Thank you, sir.